You're watching CTOM TV. Knowledge is power.
Samantha is wondering, what's the difference between Hodgkin's lymphoma and non-Hodgkin's lymphoma? And what is lymphoma?
Okay, so lymphoma is a disease of the blood cells.
The lymphatic system?
Yes, and it affects the lymphatic system.
Okay.
It's typically the B or the T cells. One of the big differences is there's really two types of lymphoma. You said there's 30.
Yes.
And definitely that's
what my surface review
That's definitely
said.
True, but we need to classify it as Hodgkin's and non-Hodgkin's.
Okay, so
two
main types.
Hodgkin's lymphoma is characterized by the presence of a type of cell called the Reed-Sternberg cells. They're a specific type of cell, and it's the same in every patient with Hodgkin's lymphoma. And because of that, they respond very well to targeted or immune-based therapies.
Because every cell has that.
Yes,
Got
exactly.
It.
Non-Hodgkin's lymphoma is a class of different lymphomas. There's many different types and many subtypes, many different molecular features. Some are more deadly than others. It really depends on the genetics of each one. But we have a host of new treatments for them. There's a lot going on.
So can I just recap there? Hodgkin's, the big difference is with Hodgkin's lymphoma, you've got the same mutation in every cell.
Not necessarily. You just have the same type of cell, the Reed-Sternberg cells.
Okay.
Yeah.
And that can be targeted.
Yes.
Okay. Whereas in non-Hodgkin's, it's a little more of a mishmash. It's not.
You're still going to be having a certain cell type, but it's not as how do I say? There's a lot more variation.
Okay.
Between different types.
It's not a one paintbrush.
No, it's not. Not like Hodgkin's.
Okay.
And so Hodgkin's is actually considered the curable form of lymphoma.
I see. So that's if there is a good one.
If there is a good one, that's the one to have.
Right,
yes.
Got it. Whereas non-Hodgkin's, tell us about that.
So there's many different types. We should be breaking this up into a few different sessions because I don't think we could cover everything today. There's just so much going on.
Okay. Well, tell us the most important bits for us to know.
Well, I thought the good thing to start with is to cover two different types that are fairly common,
okay.
And that there has been a lot of treatment going on in that.
Okay.
So typically they're B cell malignancies. B cells are known as Bursar cells. That's where they get their name from. They're a type of lymphocyte, and they're involved in the immune system. There's also T cells, but we won't get into that.
And are they jacking up the immune system, or are they suppressing your immune system?
So what happens with these B cell tumors is you get a mutation that prevents the cells from maturing into the final form of the cell. So once again, they get stuck in the stem cell reproducing mode. So they're proliferating. They have a high proliferation, but then they don't differentiate into the cell they're supposed to be. So they're non-functional. So it's basically clogging up your lymphatic and your blood system with these cells that are not functional, but are supposed to be functional.
Oh boy! So your bloodstream starts to become
Your lymphatic system, yeah, it plugs up in your lymphatic. But it can affect the blood. It can affect the bones. It can you get these clumps of tumors anywhere in the body.
So does that mean with that type of cancer, you're going to have more likelihood for metastases than other types? Or
it's body-wide. Okay. Your lymphatic system is all over the body.
Okay, so it's not considered metastases. It's just that it may show up in all these different...
Yes, you get these different spots, lymph nodes typically, that can grow into tumors.
Okay. And what's the other type? You said you want to talk about two specifically for...
So where these occur is really the big... big issue.
Okay.
So there's many types. I was going to focus on mantle cell, which is a type of lymphoma.
Okay.
There's also follicular, and then I think we'll just stop with those two for today.
Okay, because those, as you say, are some of the more common.
Yes.
Okay.
Yes.
All right. So tell us about mantle cell. What is that?
This is a type of B cell malignancy. Typically, it's treated with chemotherapy and stem cell transplants. Different protocols for patients depending on their age, because, you know, patients that are older than 65 can't typically tolerate heavy chemo and stem cell transplants. And that's typically what's required for treatment up until this day. So one of the negative prognostic features, and this is why you should always do tumor DNA sequencing, is a p53 mutation. It's always a bad thing in lymphomas. It basically means you can have an aggressive form that's hard to treat. P53, as you know, we've discussed it before, is a you know, the classic tumor suppressor gene. It's called the guardian of the genome, and so without that, you know, things get crazy quickly.
It's kind of like the gatekeeper
The
that
gatekeeper
makes
of
sure.
the genome, yes.
Yeah. So if there's
Yeah.
a problem with that, it's not working well. It's just so much easier
Exactly.
for cancer to progress.
Yes, mutations. Yes.
And why is that so much more the case, say, with mantle cell lymphoma as opposed to other types of cancer? Why do you say
It's
is-
involved with just about every cancer.
Oh, okay.
Yeah, and
All
it's usually a negative prognostic feature in
for any.
pretty well any
Okay,
cancers.
got it.
Yeah. So under 65, the typical standard chemotherapy is called R-CHOP. There's also R-DAP. These are standard. The R refers to a drug called rituximab, which is a CD20 monoclonal antibody. So one of the first few targeted therapies we have. Targets cells with CD20. A lot of B cells have that. So that is one of the protocols. R-CHOP is you know, just a variety of really old chemotherapy drugs that have been around for quite a while.
It's kind of just trying to like
A massive combo of aggressive
Let's see what
chemotherapy
works.
drugs, yes. And so you do R-CHOP or you do R-DAP, and then if you get a good response and the cancer stays away for a while, they'll do a stem cell transplant.
Okay. Oh, you mean you need to be in remission?
Yes, you need to be in remission for a period of time. It's a defined period of time.
Wow.
If you fall out of remission within that defined period of time, then you're not eligible for a stem cell transplant, or you are, it's just not going to work. You know, but typically they don't do it. So you have to be cancer-free on these drugs. You have to have a good response to these drugs before you're eligible for a stem cell transplant.
So it's back to, so we're specifically still talking about mantle cell?
Yes.
Okay.
Under 65.
Under 65. So there's these kind of two, so really standard chemo
Standard
is
chemo.
either the R-CHOP
And stem cell
or
transplant.
and
yes.
stem cell, if you can maintain that remission long
Yes,
enough.
exactly.
And do you have any idea how long that period is?
I
Like,
do,
is it
but I don't want to
a
get
year?
into that
Okay,
right now.
right.
Because
Wait for next time.
yeah, it's
That's okay.
it's going to be different in different places.
I understand.
And different doctors are going to have different ideas and how they do that. I mean, there are standards outlined by the FDA, but you know, they're kind of loose standards. And defining what a progression is and the level of the progression, and you know, it's not simple like prostate cancer where you have a 6-month doubling period of your PSA.
I see. Okay.
It's a lot more complicated.
All right. Okay, got it. Okay, so now what?
So there's been some huge developments in drugs that target lymphomas, and these drugs also target leukemias as well. Yeah. So
why is that?
A lot of similar pathways, a lot of similar mechanisms. So if you're over 65, then the combination is called bendamustine, ibrutinib, and rituximab. And ibrutinib is a new drug. It's a class of drugs called the Bruton tyrosine kinase. And it's a new class of drugs. There's a bunch of new ones now that are very, very effective. So if you're over 65, the first line, you know, you're going to have this class of drugs that's based on thalidomide. Do you remember thalidomide?
I do.
Yes.
Yes, I totally do.
Okay, so what do you know about thalidomide?
Well, I in the other hat that I wear in the world, which is mental health counseling, I've had a few clients who have been thalidomide babies,
Yes.
whose moms took this anti-nausea drug when they were pregnant, and that led to some lack of proper development and deformity of their limbs.
Right. Yes. So my sister was a thalidomide baby, my older sister, and she died. So yeah, it's hit Canada pretty hard. So what's fascinating about these drugs is they've been redone and they've been changed up because they seem to have a great role in lymphomas. They're very effective in lymphomas. So while they're not the best birth control nausea medication, they're, you know, if you're not pregnant, you know, they can have you know, they've been game changers for lymphomas.
Well, I guess that kind of makes sense because of how they influence the babies, which was to intercede in their proper development.
Exactly.
So it's going to stop those stem cells from developing.
Exactly.
Yeah.
That's a good
And
point.
when thalidomide was used for morning sickness, were there later discovered, I mean, aside from the influence on the fetus, were there side effects to the parent?
Not really, no.
Okay,
No.
so this could be a fairly well tolerated treatment then.
Yeah, it is. It does have its side effects, but it's fairly well tolerated.
Hmm.
So they've changed it. There's now lenalidomide.
A slight modification.
Yes, some modifications on it, so it's more specific for the cancers.
Hmm.
And so that combined with rituximab is a new protocol they call R squared. So lenalidomide, its brand name is Revlid or Revlomid. And if you combine lenalidomide and rituximab, the CD20 targeting molecule, so you have a great response in mantle cell lymphomas, especially for patients over 65. This is a really new finding. In fact, the 5-year survival in the first line was, I believe, you know, incredibly high, 74% or something like that at 5 years.
That's
for people
excellent.
with heavy disease.
Wow.
Yeah, so it's
so how long has this combination been like accessible?
We've been, you know, we've known about lenalidomide and we've used it quite a bit over the years. It's not. I mean, it depends on where you go.
I see.
It's used a lot more in the States, and it's relatively new in Canada because we had such a bad experience with it initially. I think there's some reluctance to try it again.
Yes. Well, yes.
Yeah.
As you say, we wouldn't use it for pregnant.
But this combination seems to work really well in mantle cell in older people. Yeah.
That's wonderful because otherwise the prognosis wasn't so good.
Yeah.
No, and again, you'd need the stem cell transplant, and you're saying with people, even the older folk.
Yes.
I say that with hesitation because I'm quickly approaching
that
age myself. But wow, that's excellent. So such a longer survival rate. And how well are these tolerated typically?
Fairly well. Yeah. The problem with this combination is it's what they call indefinite. So there are no defined no defined terms of, you know, a treatment, where you do get that with the other treatment protocols. You have a protocol, you do so many cycles. With this, you just stay on it. You know, you stay on the combination. So that's one of the you know, negative aspects of it.
Is that it's kind of a for life thing.
Yes.
But it's like
great results.
Years and years of quality of life.
Yeah.
Wow.
So in the second line treatment, BTK inhibitors, Bruton's tyrosine kinase inhibitors. I think there's 3 different players now. The ones that we're most familiar with are ibrutinib and acalabrutinib. And acalabrutinib is kind of like a second generation version of ibrutinib. It has a longer, longer progression-free and overall survival. It's much more easily tolerated. One of the side effects with acalabrutinib is headaches, but they found that if you take a shot of caffeine, the headache goes away. So that's an interesting
I find that
little.
with my migraines.
Yes. Oh, really? Okay.
Yeah, because it stops it constricts the blood vessels or some such thing. That's what my doctor told me. Why that works anyway.
Okay, so if you are on a acalabrutinib or ibrutinib, and you stop responding to it, which can happen eventually, then you have to taper it off. You can't just go off it, because what will happen is you get this massive growth. So you have to taper it off slowly. So that's one of the negative side effects of it.
So it works well, but it's kind of more holding things at bay as opposed to taking them out.
Oh yeah, it works incredibly well. Yeah, Bruton's tyrosine kinases definitely work well. Second line, third line. There's a new drug. Well, it's not that new. It's a BCL2 inhibitor. It's called venetoclax. And so venetoclax is basically what we call a BH3 mimic. And BH3 is what binds BCL2 and inhibits it. And this is involved with apoptosis. So BCL2 is involved with pre-programmed cell death. So basically, BH3 is involved in that process. So
And BTK, this is a BTK inhibitor.
No, this is a BCL2 inhibitor.
Oh, B, so sorry, I got confused
Yes.
here. That's the venetoclax you're talking about.
Venetoclax.
Okay.
So that seems to work really well too as a third line. So once patients stop responding to this, the BTK or the R squared, then they can have a nice long extra time on venetoclax. So for cancer, that was fairly had fairly bad prognosis.
Yeah, the mantle cell.
Mantle cell. We've got these different lines of treatment now, the targeted therapies that work incredibly well.
So if someone were to start on the R squared, for example, as you say, recent studies are showing 74% 5 years.
5 years,
so you could do that for 5 years, and then you could try these BTK inhibitors for a good chunk of time, and so on. And the exciting thing, if you're paying attention, there's new treatments coming out all the time.
Yeah.
So very likely, as you're getting to the tail end of the R squared, that first line treatment, there'll be something even better than what you're talking about now.
Right. And then there's CAR T cell.
Okay.
So I believe we have 3 CAR T cell drugs now. I've just been following the first one. Tisagenlecleucel.
That sounds like how I'd pronounce it too.
Kymria. And Kymria is its brand name.
Okay.
So there are, I believe there's 3 of them now.
You mean chimera, I suspect, right?
Yeah.
Okay.
Yeah, with a K.
Oh, with a K.
Chimera.
Okay. If you were going to look this up at home. Okay. All right. So that's a CAR T cell.
Kymria.
Oh, Kymria. Okay. Do we have it spelled somewhere so we can tell people? No. Okay. All right.
We don't really do CAR T cell therapy where we are because it's just so expensive.
You mean in Canada?
Yeah, it's so expensive. $500,000, but it's been recently approved.
Why so expensive? What is involved in this treatment? It's an expensive
process, an expensive drug. We're going to see it go down, but it's just, it's not quite ready for prime time yet, in my opinion. We don't know how to determine which patients are going to respond, which patients are not going to respond.
Hence, you're just watching it.
We're watching it, yeah.
Got it.
We're watching it. And, if a patient has run out of, all other options and they can afford to pay for it, by all means, it's a treatment that could be on the table. So typically CAR T, what it does is they target, most CAR Ts target something called CD19.
Okay. Yeah, we hear lots about that. What is CD19?
It's a molecule that's present in most B cells.
I see.
In most cancer B cells.
Okay. Okay.
So now we're going to look at diffuse large B cell lymphoma.
Okay.
And so this is the worst case scenario. What happens?
Worst diagnosis?
Yeah. So most lymphomas will eventually turn into a diffuse large B cell over time. Patients may not live long enough for them to get to that stage, but it is the worst case scenario, and it's basically like you have to consider that as an advanced stage of lymphoma.
Okay.
And there's two subtypes. There's what we call the germinal center, and then the activated B cell center. And so the worst type to have is the activated B cell. It doesn't respond very well to treatments, and it's the one that typically you see when people die from lymphoma. That's typically what they have is the activated B cell version.
So you can just kind of start out with that if you're very unfortunate. Otherwise, many lymphomas will just naturally transgress that. Okay.
It's basically called large B cell. So one of the treatments for chemotherapy is called R-ICE, and that's a combination of rituximab, ifosfamide, carboplatin, and etoposide. These are standard chemotherapy drugs. There's another combination where you replace gemcitabine and oxaliplatin and combine it with rituximab. So those are the 2 standard ways of dealing with that. The latest standard treatments. Okay,
most current. Common.
Right. Now, also, another study has just found out that for the ABC subtype, the bad one, R squared, the rituximab and lenalidomide that we talked about previously, is very effective relatively new study. So we're seeing some new data on that.
Ooh.
So that could be a game changer for us.
Could you tell me why? Why do you think that treatment is working so well for those people?
We're not sure yet.
We don't know yet.
No.
So we don't have a defined mechanism?
No, we do.
We do.
There's many defined mechanisms, and we'd have to spend quite a bit of time talking about them if you want to.
Okay.
We're just talking about things generally here because there's a lot to get into.
All right.
So
we're not sure why, but it works well.
Well, we know some of the mechanisms, but R squared seems to work in this combination too.
Okay, that's great news.
It is great news.
Wonderful.
Yes. Yeah.
So this is for the
but
large
specifically
B-cell.
for the ABC subtype, which is the non-germinal center, the activated B cell subtype, which is not, which does not respond well to standard treatment. Right. So it's good to have something for that.
Holy cow! Yes.
Once again, CAR T cells. They seem to do really well. One of the problems with CAR T cells is something called cytokine release syndrome.
Okay.
And what that is it's a process where these proteins called cytokines get released, and they can affect the blood-brain barrier and cause neurotoxicity in the brains. Oh. So that's one of the bad negative side effects of CAR T cells. Mm-hmm. We're not entirely sure how that works, but there's some recent data to show that there's actually some pathogens, like viruses and bacteria and so on, that also express CD19 that live in the endothelial cells in the blood-brain barrier. Oh. And so when you give them a CAR T, it's going to attack them there and cause problems. Mm. And so typically when you have this cytokine release syndrome, you almost always end up with neurotoxicity. Oh. And so this seems to be a common problem with all CAR T therapies. Oh, okay. So it's a limiting.
One of the reasons why you're watching, aside from the budget requirement.
Exactly. And so, typically when people turn to CAR T therapy, it's because they have a high tumor mutation or high tumor burden. They have a lot of cancer. Mm. And those are the people that are most likely to get cytokine release syndrome and have this neurotoxicity. Mm. So, that's one of the problems there. There's a new drug. We've been watching this drug for a while, actually a couple of years now, and we've actually used it in 2 patients and then had great results. It's called polatuzumab vedotin, and it basically it's a new class of drugs called the antibody conjugate, and so it has this antibody for CD22 and CD79B. And then it attaches a drug called MMAE, chemotherapy drug, that attaches, and it brings into contact all these players. And so it's like targeted chemotherapy. Wow. So it seems to work really, really well. In a recent study in ASH, which is a international conference, and ASCO, and ASCO is an international conference too. They showed that for really late stage people, when they combine it with the standard combination called BR, bendamustine, plus this polizumab vedotin, they changed the survival rates, and these are patients that weren't really doing well. Mm-hmm. They changed the survival rate from 12 months compared to 4 months without the drug.
Oh, wow.
So that's quite a difference. It's an extra 8 months added to end stage disease. Mm-hmm. Definitely.
That's pretty good, really, if you're already at end stage, to be able to have another 8 months to a year.
Yes, totally.
Yeah. Wow. And as we were talking about before, there's so many of these newer treatments that are giving you so much more time to start with.
Exactly.
So by the time you got to this, you'd be 10 years down the road, right. Potentially.
Potentially, yes. Mm-hmm. Yes.
Yeah, that's great. All right. So that was mantle cell, an exploration.
Diffuse large B cell.
Got it. So
mantle cell was first.
Okay, sorry, because you said you want to talk about 2 kinds. Yes. There was the mantle cell and the follicular. So
mantle cell and diffuse large B cell.
Oh, sorry, I wrote that down wrong. Okay.
I mentioned follicular. Sorry, we'll use it. We'll do that one next week.
Time. Okay. All right. So we are on track. Then I was wondering when we were getting to this other piece, but you're on it right now. This large B cell.
Yes.
Okay. What else do you want to tell us about that?
With large B cell, it's really important to know whether you're the germinal center or the activated B cell. There's a couple of different ways that you could do it through molecular tests. You can do it through genetic testing. They have different, different genetic mutations that define the subtypes. So you want to know that.
And what are those two subtypes again?
Germinal center and ABC.
ABC.
So germinal center B cell and activated B cell.
Okay.
ABC.
And I mean, I can appreciate in cancer, you want to know as much as you can, but why do I want to know the difference between those two?
Because the ABC has a really poor outcome.
Okay.
And it's not going to work with standard therapies.
Okay. All right. And the germinal
is better.
Yes. Simply put, better. Yes. All right. Okay. So are there other treatments that you wanted to tell us about, or anything you want to tell us about diagnosis or enhancing treatment?
Once you get past these standards, these are for non-stratified patients.
Which means what?
They don't have genetic testing.
Oh, okay, all right. So we still have a whole conversation to have about if you do have genetic testing. I see.
Exactly.
So this is for folks who haven't had any additional testing and they've just been diagnosed with this type of cancer and they're getting standard treatment.
Yes.
These are the new standard treatments.
No, they're not the new standard. They're new standards somewhere.
They're
in some hospital.
New standards.
These are the ones you want to ask for.
Okay, right. So you have to advocate for yourself potentially to get these, but they are available.
They are available through clinical trials. The problem is most of the doctors are just they don't know when to apply these.
Right.
And they don't know what situations they're going to work in. And so they're not part of the standard care in Canada. Some doctors do know about them and will automatically put you on them. The fact is that you need to be proactive and you need to know about them yourself and you need to request them.
Yeah, good. That's the most important piece, really, isn't it? Is your knowledge about what's possible and
genetic testing,
and being a squeaky wheel and really advocating for yourself. And then
because then you'll know for sure what's going to work better with you. For example, if you have a BCL2 mutation or overactivation of BCL2, then you know that regardless of what subtype you have, venetoclax is going to really be a beneficial drug for you. So tumor DNA sequencing, proper diagnostics, and then follow those guidelines.
So yes, because once you know what your genetics are, then we're talking a whole cornucopia
of combinations that you can add to these drugs.
Yes,
exactly.
Right. Which adds more time and typically fewer side effects.
Better targeting.
Do you have an example that you wanted to offer about, or are there common mutations? I know certain like we hear about how in breast cancer, not everyone by any means, but there's often the BRCA mutation, for example.
Yeah.
What about in these types of cancers? Are there some common mutations?
There are. They're not your run-of-the-mill mutations. Lymphomas have, they have the standard mutations that most cancers have, like the P53 and so on. But most of those standard mutations are not directly targetable. So, what we would be looking for is unique mutations, like, mutations in BCL2 or mutations in the genes that the drugs target. So we can say, hey, this drug's going to be much better for you than that drug.
Right. Yes. And then that's the thing, right? Not only does it give you more options, but it gives you more confidence when you have that.
Yeah, you have a better idea whether you're going to get some, some response.
And for people with this type of illness, is imaging technology like PET-CT beneficial?
Yes, PET-CT is very beneficial.
It is.
Definitely. Definitely in lymphomas. You want to use PET-CT to see how your treatment's working.
Okay, so not so much for staging or initial diagnosis.
Staging, but for monitoring. Initial diagnosis, and monitoring.
Okay. Okay. So I seem, for some reason, I have it in my head that certain types of cancers don't work so well with PET-CT, or meaning you don't see them as well.
Depends on the isotope.
Okay.
We have many new isotopes now.
Okay.
I think you're probably referring to prostate cancer.
Probably.
Yes.
Okay. So this is two thumbs up for a diagnostic PET-CT and for monitoring PET-CT.
Totally, yes.
Yeah, our website, ctome.com, has some really good information and articles on the difference between all the different imaging technologies, CT, MRI, ultrasound, mammogram, and PET CT. So if you want to read some more about that, you can find out some more there. Okay, we have one question that I'd like to ask. It came in as we started our deep dive into non-Hodgkin's lymphoma. Was there anything else you wanted to make sure people at home know before we?
Make sure you get the newest access to the newest and latest technologies. It's really, really important.
So if I'm Mrs. Smith and I'm at home and have no experience with cancer whatsoever, and some guy on Facebook is telling me to get access to, why do I do that? How do I do that?
Because you can't expect the doctors to do that for you.
No, but how do I do it if I don't know anything?
How do you do it? You call us.
Call us. Okay.
If not, you go to the conferences. You read you look at the conferences and see what's being offered. There's many great websites. OncLive is great.
OncLive, OncLive.
PubMed is the master database.
PubMed, PubMed.
And what's the other one? ASCO Posts is a good one.
ASCO Posts.
Yeah, they do nice summaries of all of the new seminars.
Okay, so you could educate yourself on what's going on in
definitely.
And
then just take a copy of the study and take it into your doctor and say, what about this? Is this going to help me? Can this apply to me?
Yes, that would be the thing. And then, okay, so what if you've taken in this study that you see is fairly current, and your doctor says no?
You get a second opinion.
Okay, and this is where you come in again. You and your team. And it's true. It's true, actually, that your second opinion
from a different hospital. I think it's important to have many opinions.
I also find, I'm answering my own question there, but if you decide to do your own research, you must make sure it's one of these peer-reviewed, reputable medical science-based sites. Otherwise, you must understand why your doctor can't support what you're asking for. And if your doctor suggests that that's not necessary for you, make them tell you why.
Exactly.
Make sure that they understand that this current study is there, and that they can actually tell you why that's not relevant to you. Because sometimes they really just haven't heard of it. Yes. Or in public health care, there are legitimate barriers to the kinds of things your doctor can advocate for you for because of finances and limitations in our system, which isn't the same thing as it won't work for you or that your doctor won't prescribe it for you. But there is definitely some negotiation to be done. And
ask for the data. If your doctor is telling you, I think this is best for you, we're going to give you this, say, okay, can I have a copy of the clinical trial with the progression-free, the pathological complete response rates, the overall survival rates? Please, I want that data.
Yeah.
So I know that it's best for me.
This is your life.
Exactly.
So don't hesitate.
And if they don't have the data, they shouldn't be talking about it.
That's right. So, and if they can't give you a reason why the data you're bringing isn't as good as what they're offering, then that's definitely
a good indication to switch things up.
Yeah.
Thank you for watching CTOM TV. Subscribe below and stay informed.